Good morning. My name is Amul, Tutor, Psychology College of Nursing. Today we are going to discuss about the eclampsia. What is eclampsia? First, let us see the introduction. Eclampsia is a series of pregnancy characterized by seizure in the setting of preeclampsia. Typically, the pregnant woman develops hypertension and proteinuria before the onset of convulsion season. Any of these symptoms may present before the after a seizure occurs. Definition: postpartum eclampsia is a series of conditions that can happen after childbirth within 6 weeks after delivery. This will cause the woman to have high blood pressure and high levels of protein in the urine, leads to brain damage, stroke, HELP syndrome, and death. Incidence: the hospital incidence in India ranges from 1 in 500 to 1 in 30. It is more common in primigravida, 75%, 5 times more common in twins than in single-tone pregnancies. It occurs between the 36 weeks and terms in more than 50%. Life-threatening emergencies most common in third trimester. Approximately 60% of cases precede delivery, incidence higher in developing countries. Then incidences they are having three for antepartum and intrapartum and postpartum. Antepartum period is 50% cases are affecting and intrapartum is at some 25% of cases are affecting and postpartum is 25% of cases are affecting. The time of onset 91% of cases increased or less than equal 28 weeks of gestation, 77.5% of cases 21 to 27 weeks of gestation, and 1.5% of cases less than 28 weeks of gestation. Then causes. Exact etiology is unknown, but common in previous hypertension diseases, failure of presentation and abnormal lipid metabolism and decreases of calcium in diet and other causes ALDEPR. A for alcohol, C for coarctation of aorta and C D for drugs, E for endocrine diseases, and P for pregnancy-induced hypertension or for renal diseases. Then risk factors: uncontrolled high blood pressure before pregnancy, high blood pressure during present pregnancy, family history of postpartum preeclampsia, under the age of 20 and over the age of 40 years, and obesity. Having certain diseases like diabetes, lupus, rheumatoid arthritis, or some kidney diseases, multiple gestation, family history of cases, preeclampsia or eclampsia in family members for single yes, genetic predisposition to the condition, obesity, the women who are obese are at a higher risk of developing eclampsia than others. Then pathogenesis. Thromboplastin, renal glomerulus affect the proteinuria, general vasoconstriction, hypertension, headache, visual disturbances and seizures, imbalance in prostaglandin ratio, placental vasoconstriction, reduced perfusion and releases of angiotensin 1 and angiotensin 2 and adrenal hormones, aldosterone, sodium reabsorption leads to the edema and oliguria. Causes of convulsion: cerebral irritation leading to convulsion, and the irritation may be provoked by anoxia, cerebral edema, cerebral dysarrhythmia, anoxia, spasm of cerebral vessels, increased cerebral vascular resistance, fall in cerebral oxygen consumption, and anoxia. Then cerebral edema, it may contribute to irritation. Cerebral dysarrhythmia, it increases the following anoxia and edema. Then course of convulsion, seizure lasts for 60 to 70 seconds, clonic type, later goes into coma. Throughout seizure, diaphragm is fixed. Breathing does not occur. First convulsion is forerunner of others, maybe 1 hour and 1 or 2 hours in mild cases to continue result in status of preeclampticus. Antepartum 50% which occurs before onset of labor, more often labor starts soon after. At time it is impossible to differentiate it from of intrapartum ones. And if intrapartum 30% which occurs first time during labor, postpartum 20% which occurs for the first time in puparium, usually within 48 hours of delivery. Fits occurs beyond 48 hours but less than 4 weeks after delivery is accepted as late postpartum eclampsia. Then clinical features, pre-monitoring stage, tonic stage and the chronic stage and the stage of coma. We will say one by one. Pre-monitoring stage. First, clinical manifestation. The eclamptic phase or epileptiform consists of four stages that are: first, we will see the pre-monitoring stage. The patient becomes unconscious. There is stretching of muscles of the face, tongue, and the limbs. Eyeballs are turned to one side and they become fixed. This stage lasts for about 30 seconds. This is the pre-monitoring stage. Then tonic stage. The whole body goes into a spasms called trunk apostomus. Limbs are fixed and hands are clenched. Respiration causes a tongue protrudes between the teeth. Cyanosis appears. Eyeballs become fixed. This stage lasts for about 30 seconds. This is the tonic stage. Then chronic stage. All the voluntary muscles undergo alternate contraction and relaxation. The switching starts in phase, then involve one side of extremities, and ultimately the whole body is involved in the convulsion. Biting of tongue occurs. Breathing is sterile, blood strain for the secretions fill the mouth. Cyanosis gradually disappear. This stage lasts for 1 to 4 minutes. Stage of coma. Following the patient passes one the stage of coma. It may last for a brief period or in others deep coma persists till another convulsion. On occasion, the patient appears to be in a confused state following the fit, fails to remember the happenings. Rarely the coma occurs without prior convulsion. Other clinical features: high blood pressure, usually over 140 by 90 mm of Hg, high levels of protein in a individual urine called proteinuria, headache, changes in vision, and the swelling of the face, hands and feet or limbs, nausea and vomiting, pain on the upper right side of the abdomen, decreased urination, blood division, and the rapid weight gain. Complications. Maternal complication are as follows: tongue biting, head trauma, aspiration, broken bones, permanent CNS damage, intracranial hemorrhage, renal failure, death, and the injury due to falling from bed, disrupted vision, and the psychosis and the shock. These are all the maternal complications. Acute left ventricular failure, pneumonia, acute respiratory distress syndrome (ARDS), and pulmonary edema, hepatic necrosis. Then neonatal and fetal complication, death, prematurity, placental infraction, abruptio placenta, and fetal hypoxia, aspiration, etc. IUGR, intrauterine growth retardation, and sepsis. These are the neonatal and fetal complications. Tongue bite. and intracranial hemorrhage and premature infants and abruptio placenta. There are three classifications is there: external abruption and relatively concealed abruption and concealed abruption. Then fetal hypoxia, the bluish discoloration, the baby will change. This is a fetal hypoxia. Okay, then IUGRs, these are all the IUGR babies. These are all the complications. Then prognosis, maternal prognosis. Once the convulsion occurs, prognosis become uncertain. Prognosis dependent on many factors. Long interval between onset and the commencement of treatment. Antepartum eclampsia, especially with a long delivery interval. Number of fits more than 10. Coma in between fits. Temperature over 1 or 2 Fahrenheit with pulse rate above 120 per minute. Systolic blood pressure above 200 mm of Hg. Oliguria with proteinuria, non-response to treatment, jaundice, respiration rate 40 per minute, coma taken 6 hours or more. Then maternal mortality in eclampsia is very high in India because of cardiac failure, pulmonary edema, aspiration and septic pneumonia, cerebral hemorrhage, acute renal failure, cardiopulmonary arrest, ARDS, pulmonary embolism, postpartum shock, peripheral sepsis. Then fetal prognosis. Mortality rate is high, about 30 to 50 percentage of cases are prematurity, spontaneous or induced intrauterine asphyxia due to placental insufficiency arising out of infraction, spasm of uteroplacental vasculature, and the retroplacental hemorrhage, effect of drugs used to control convulsion and the hypertension, trauma during operative delivery, management. The aim of management, prediction and prevention, first aid treatment outside of the hospital, general management and medical and nursing, specific management and obstetric management. Aim of management, arrest convulsion, maintenance of management, airway, breathing and circulation, oxygen administration at the rate 8 to 10 liter per minute, terminate pregnancy, ventilatory support, prevention of complication, hemodynamical stable, prevention of life-threatening situation, postpartum care, medicine, and the regular follow-up. Prevention, prevention. The majority of cases, eclampsia is preceded by preeclampsia, early detection, and the effective institutional treatment with the judicious treatment of pregnancy during eclampsia, antihypertensive drugs, anti-convulsion therapy, timely delivery of baby, close monitoring during labor, and 24 hours of postpartum. Use of magnesium sulfate lowers the risk of eclampsia. First aid treatment outside of the hospital. Important steps in transport are all maternal records and delayed summary should be sent with patient. BP should be established and convulsion should be arrested. Drugs should be given like magnesium sulfate, labetalol, diuretics, diazepam. One medical personnel and a trained midwife accompanying the patient in equipped ambulance to prevent injury and complication. General management, medical and nursing, supportive care, prevent serious maternal injury from fall, prevent aspiration to maintain airway and to ensure oxygenation. Patient is kept in real pot and trunk depressor between teeth, kept in the lateral position to avoid aspiration, vomitus, oral secretions are removed by frequent suctioning. Oxygen is administered to prevent respiratory acidosis. Oxygenation is monitored using a transcutaneous pulse oximetry. ABG analysis is needed when oxygen saturation falls below 92%. Sodium bicarbonate is given when pH is below 7.10. The patient should have a doctor or at least a trained midwife for concerned supervision. History. Delayed history is to be taken from relatives relevant to the diagnosis of eclampsia, duration of pregnancy, number of fits, and the nature of medication administered outside examination. Once the patient is stabilized, a throughout of quick general abdominal and vaginal examination are made. A self-retaining catheter is introduced and the urine is tested for protein. Monitoring hourly, half-hourly pulse and the respiratory rate and the recorded hourly urine output is to be noted. If undelivered, the uterus should be palpated at the regularly intervals to detect the prognosis of labor and the fetal heart rate is to be monitored. Immediately after convulsion, fetal bradycardia is common. Fluid balance. Ringer solution started as first choice. A excessive of dextrose or crystalline solution should not be used as it will aggravate the tissue or overload leading to pulmonary edema. Circulatory overloaded ERDS antibiotic to prevent infection and ceftriaxone 1 gram IV BD. Specific management. Anticonvulsant sedative therapy. Magnesium sulfate is drug of choice. It acts as a membrane stabilizer and a neuroprotector. It reduces monitor and palpate sensitivity to acetylcholine. It induced cerebral vasodilatation, dilate uterine arteries, inhibit palpate activation. It has no advisor effect on neonate within therapeutic level. It has got excellent result with maternal mortality of 3%. It does not control hypertension. Anti-convulsion therapy. Repeat injection are given only if knee jerking or present, respiratory rate more than 12 per minute, urine output exceed 30 ml per hour. The therapeutic level of magnesium is 4 to 7 milliequivalent per liter. For recurrence of fits, 2 grams IV bolus is given over 5 minutes. Then regimens of magnesium sulfate for the management of severe preeclampsia and eclampsia. Intramuscular regimen. Richard regimen is loading dose 4 grams IV over 3 to 5 minutes followed by 10 grams deep IV and 5 grams in each buttocks. Then maintenance dose 5 grams IV 4th hourly in alternate buttocks. Then in second one is the intravenous regimen, choose one and a Sibai regimen. 4 to 6 grams IV over 15 to 20 minutes loading dose. 1 to 2 grams per hour IV infusion is a maintaining dose. Then benefits of magnesium sulfate use. It controls the fits effectively without any depression effect to the mother or infant. It reduces the risk of recurrent fits, and it reduces the maternal death rate at 3%. It reduces the perinatal mortality rate. These are all the benefits of magnesium sulfate. Other regimen, phenytoin, diazepam, lactic cocktail regimen. These are drugs is chloropromazine, pethidine, promethazine. These are all the lactic cocktail regimens. Then antihypertensive and diuretics, drugs and dose. Drugs is a methyl dopa oral 250 mg BD IV 250 to 500 grams milligrams. Labetalol orally 100 mg thrice daily IV 1 to 2 milligrams per minute. Hydrolyzing oral 10 milligram per day in 4 divided doses. Nifedipine orally 5 to 10 milligram thrice daily. Presence of pulmonary edema, furosemide 20 to 40 mg IV. Then management of diuretic fits. The in pre-monitoring stage, a mouth guard is placed in between teeth to prevent tongue bite and removed after clonic stage or phase is over. The air passage is to be cleaned with mucus sucker. Oxygen is given until cyanosis disappears. Status of eclampsia, thiopentone sodium 0.5 mg dissolved in 20 ml of 5% dextrose is given IV very slowly. In unresponsive cases, cesarean section is ideal for life saving. Treatment of complication. Prophylactic use of antibiotic markedly used reduced the complications like pulmonary and puerperal infection, pulmonary edema, furosemide 40 mg IV followed by 20 mg of mannitol. Then treatment of complication. Prophylactic use of antibiotic markedly reduce the complications like pulmonary and puerperal infection. Then heart failure, oxygen inhalation, parenteral lasix and digitalis anuria. The dopamine infusion is given. Hyperpyroxia, cold sponging and antihyper antipyrotics are given. Psychosis, chlorpromazine and triflupromazine is quick effective. Then intensive care monitoring. The patient with multiple medical problems to be admitted in ICU. Cardiac, renal or pulmonary complications are managed effectively. Blood gas analyzer, pulse oximeter and CVP monitor to be used. The unconscious patient needs steroids and or diuretics. CT scan or MR may be needed for the diagnosis. Then labetalol injection. Then this magnesium sulfate and the thiopentane sodium. These are the medications, antihypertensive drugs. Then obstetric management during pregnancy. The majority of cases with antepartum eclampsia, labor starts soon after convulsion. Labor fails to start. The management depends on whether the fits are controlled or not. The maturity of fetus. Fits are controlled. There may be three conditions like a baby mature, baby premature, baby dead. Baby mature, the delivery should be done. The cervix is favorable and there is no contraindication of favorable delivery. Surgical induction by low rupture of the membrane. When the cervix is unfavorable, cervical ripening with PGE2 gel could be achieved before ARN. If cervix is unfavorable, and or there is obstetric contraindication for vaginal delivery, cesarean section is done. Baby premature less than 3 weeks, less than 37 weeks. The delivery is recommended in onset of ICU. NICU, the underlying diseases process of preeclampsia and eclampsia persists until woman delivers. Moreover, there is a risk of convulsion IUFD. Steroid therapy is given when pregnancy is less than 34 weeks. Conservative management at early pregnancy to improve perinatal outcome, carefully balanced with maternal well-being. Baby dead. The preeclamptic process gradually subsides and then eventually expulsion of baby occurs. Otherwise, the medical method of induction is started. Fits are not controlled with an anticonvulsion within a reasonable period, 6 to 8 hours. Termination of pregnancy should be done. Duration of labor in absence of any contraindication to vaginal delivery. As soon as labor is established, low rupture of membrane is done to accelerate labor. Then follow-up and prognosis. The patient should be in follow-up by 6 weeks. Persistence of hypertension, proteinuria, and abnormal blood biochemistry necessitates further investigation and consultation with a physician. Further pregnancies should be deferred till they, they are controlled. Then postpartum management and prevention. Assess the blood loss and the sign of shock. Assess the signs and symptoms pre-eclampsia for 48 hours. Magnesium to prevent the seizure. A regular checkup. Advice to take adequate rest. She should be on a well-balanced diet rich in protein, salt-restricted diet to be advised. Screening test for early detection and the prevention of preeclampsia helpful. Summary. Definition is postpartum eclampsia and the risk factors of postpartum eclampsia and the etiological factors of postpartum eclampsia, clinical features of postpartum eclampsia, diagnostic features of postpartum eclampsia and the management of complication of postpartum eclampsia. These are all the eclampsia patient we were going to follow this medications everything. Okay, thank you.